I don't know how other hospitals function. We have a wait list because unfortunately we're understaffed and a ton of patients. So at 2 p.m., if I don't have any more patients to see, I can go to that wait list. But if I'm covering the ED at 2 a.m. and don't have any calls, a patient that's admitted that I go try to see at 2 a.m., they would laugh in my face.
So would their nurse would be like, absolutely
Yeah.
not, right? Like
Yeah.
you're not coming
Yeah.
in this room.
Yeah.
Yeah, so I think that's a little more difficult. So when we imagine that emergency department of the future, right, I think we have to consider whether productivity requirements make sense in this setting. Welcome to In the ED Now podcast that makes you an excellent emergency department physical therapist. I'm your host, Dr. Griffith, and I have with me today Dr. Cassie. Welcome to the show.
Hi, thank you. Excited to be
Well,
here.
I am so excited to talk to you because I've been like kind of communicating with you back and forth about ED related stuff, and I feel like you and I have a lot of shared perspectives, but really different experience. So tell us a little bit about yourself.
I graduated almost 9 years ago, I guess. I started in outpatient physical therapy and loved it, but wanted something different. And the healthcare system I work for was starting an ED project, an ED program. But they had no outpatient therapists involved in it. It was just purely acute care therapists. So there was some key points that I felt they were missing. So 2018, I got involved there on a once a week basis and then grew to love it and now work in acute care full time and do the ED weekly and glad I made this decision.
I love that. So, like what you are describing is like a typical path for most people that they're acute care therapists and they end up in the emergency department, whether they're voluntold to do that, whether they initiate that, or whether they get recruited to do that. And I get asked a lot of the time, should I staff my emergency department practice with acute care therapists or outpatient therapists? And I have a lot of opinions about both of those things and the fact that we silo ourselves as acute care therapists or outpatient therapists, inpatient, outpatient rehab, like
Yeah.
that's a whole nother soapbox. But so what I would love to hear from you is now that you've seen both sides, you started as an outpatient therapist and you're now what you would call an acute care therapist, yeah? You
Yep.
kind
Yeah.
of made that transition.
Yeah.
What do you feel like is better?
Better as far as what I prefer, or
What would you say to somebody who says, should I staff with an outpatient therapist or an acute care therapist?
I think it all depends on the goal of the program. For us, it was twofold. I mean, to save admissions to the hospital, patients that are coming in for something that typically they would be admitted to. They fell and fractured an ankle, uh, I don't know, dementia that can't manage at home anymore, keeps wandering, things like that. So saved admissions with that, where the acute care piece comes in. But then we also get a lot of patients with back pain, neck pain, vertigo that come in that we see them do our eval in the ED and then get them set up immediately with outpatient. So I understand your point, and I think I agree with it that we shouldn't silo ourselves in acute care or
Yeah.
outpatient or rehab because we do get all of this stuff in our education. Like back pain is in your scope, whether you're home health, whether you're rehab, intensive, SNF. I think, I don't know, the way our health system works, I think you definitely need somebody or people that have both, see both sides of things. So whether you
Yeah.
staff it with purely acute care, quote, acute care therapists, I think it's still beneficial to get input from outpatient therapists.
Yeah, and I would argue that that's more of a mindset, right? And that you can have that mindset of I'm just an outpatient therapist or I'm just an acute care therapist or I'm an all patient therapist and I can see a patient regardless of the building that I'm in.
Right.
Right. But what I love about what you're saying is that you need a variable skill set in order to be successful in the emergency department. So my next question is, when you made that transition from the outpatient clinic to the emergency department, what surprised you the most and what skills did you feel like you didn't have that you needed to uptrain a little?
I think I definitely needed to gain more training with vestibular. I was treating vestibular outpatient, but most of the time, those patients would come to us having gone through some testing and differential
Yeah.
diagnosis. And so it's pretty cut and dry, like, okay, this is why they're here. But in acute care, you don't know if they're there for a posterior stroke or if it's true a BPPV or orthostatic hypotension. So that's one thing that I definitely had to train up on. To kind of piggyback off of that and answer the other part of your question, what surprised me the most? I think the lack of understanding and education that other healthcare providers get with a lot of things, dizziness, back pain, musculoskeletal problems.
Mhm.
I don't know if we can necessarily fault them because they have to learn a lot to be an
Right.
emergency provider, but it's amazing how they hear dizziness and automatically assume vertigo, vestibular.
Yeah. Uh, I think part of the issue is they have to know so much about so much.
Yes, yeah,
And I would argue that the stuff they don't know a lot about is the stuff that's not emergent or life-threatening, right? Like,
yeah. I think that's valid.
can they put it into two buckets, like sick and scary, not sick and not scary? And if I have to have them know a ton about one of those two categories, I definitely want it to be this one, where they really know a lot about what's going on with the scary, sick things and not as much necessarily with the not scary things. Those are things they can take their time with, those are things they can consult on, those are things they can refer out. So I totally get that. Just like you and I know a lot about the not scary, not
Yeah,
serious things, but we know just enough to refer them to someone else when it is scary. So
right.
I think we just have different depths of knowledge on different sides of the spectrum. But it can be kind of surprising because I think we also just have this myth that physicians know everything, right? Like that they're
Yeah,
taught everything.
yeah,
But when I think about it, like really their musculoskeletal course in a lot of programs is like a few days of content, maybe a week. I've
right.
done some elective lectures for physicians about low back pain, about how to like do special testing for the knee. And that may be the only content that they get on that. So really, I think it's hard to expect them to also stay up to date with all of that, which is why I think we're truly the right provider at the right time in the emergency department. And I know you have some examples of that.
Yeah, yeah. I think we really complement the physician team well, and I would imagine most programs with PT in the ED department or the emergency department have really gotten the buy-in and the respect from the doctors, nurses, nurse practitioners.
Yeah, and I think that's another barrier is a lot of those providers also don't know a lot about what physical therapy can provide, right?
Yeah,
Because when you think about other physicians that they work with PT a lot, orthopedists, neurologists, pediatricians, they
right,
might have a lot more crossover, but emergency physicians just don't have as much exposure to us as a specialty. But
right.
I agree with you. Once you show them what you can do and how you can help them, I feel like we can be invaluable.
Yes, definitely. We staff our program until 8 p.m., but we had providers over the years that have jokingly, but also I think somewhat seriously expressed that they wish we were there 24/7.
And I think there's a good argument for that, right? The
Right? Yeah.
emergency department is open 24 hours a day, and
Yeah.
to only have some services part of the day can be a limiting factor that those people are inherently getting a different level of care.
Right.
But I also think there are some reasons that we shouldn't do that. The silliest reason is nobody wants to do PT at 2 o'clock in the morning, especially the physical therapist. But when you think too, if you're doing a home safety evaluation with Margaret, who came in after falling with a UTI, do you think that patient's going to present as safe to go home at 2 o'clock in the morning when she's sundowning, when she's exhausted, when she's in the
Right.
middle of her medication schedule, she hasn't eaten? Like, it's maybe not the optimal time to do that evaluation. But you
Yeah.
might be able to see Joe, who just sprained his ankle falling down the stairs after being at the bar. Like, there are different patient populations I think we could see.
Yeah. Yeah, I think you have a point. There have been several patients where I'll come in the morning to them sitting in the ED, and there's a note from like 3 a.m. The nurse or the physician tried to get them up and walk them, and it didn't go well. And then I go in, and it's like a completely different picture. And I mean, I joke with the patient, well, yeah, I don't think I would walk very well either at 3 a.m. but
Well, and also family members may not be in the best state to take care of people at 3 o'clock in the morning. I don't like taking care of my family members at 3 a.m. either. I like to be asleep during
yeah,
that time.
yep,
But I also like, from a logistical perspective, case management's not usually available at 3 o'clock in the morning, nor are they accepting rehab facilities, home health
correct.
agencies, places you can refer people at 3 a.m.
Yeah,
So I would like us to go to a 24/7 model eventually, because I also think that a tool that's not available to physicians in the emergency department all the time is going to be less utilized than one that's always available.
yeah.
My question for you about that is, do you think you could hit productivity at 2 a.m.?
No, I don't think so.
Right.
I think like anything else in any setting, it's feast or famine. And I don't know how other hospitals function. We have a wait list because unfortunately we're understaffed and a ton of patients. So at 2 p.m., if I don't have any more patients to see, I can go to that wait list. But if I'm covering the ED at 2 a.m. and don't have any calls, a patient that's admitted that I go try to see at 2 a.m., they would laugh in my face.
So would their nurse would be like, absolutely
Yeah.
not, right? Like,
Yeah.
you're not coming
Yeah.
in this room.
Yeah.
Yeah, so I think that's a little more difficult. So when we imagine that emergency department of the future, right, I think we have to consider whether productivity requirements make sense in this setting. What do you think about that?
That's a tough one. Um,
It is. So think, like, I get likened to the respiratory therapist a lot, right? So the director of our emergency department's like, I want you sitting here available to me like the respiratory therapist. Because if you go and float to a different floor and I need you, you've now delayed everything here.
yeah, and I can see that.
Yeah, but from a productivity standpoint, can you afford to sit there and do nothing?
No, you can't. Unfortunately, that's the way it's built in our
Right.
system.
So I think until we are like other ED providers that say the entire emergency department is empty, they just sit and wait for patients to come to them. But our typical physical therapy like models don't really allow for that.
They don't. You're right, unfortunately. I mean, the healthcare system I work at, we're, I guess, fortunate that our productivity standard when we're in the ED is a little less intense, but it's still there.
Yeah, well, for sure. And I think it's just sort of the nature of what we do. But when I imagine like ideal state, I think that would be a thing that I would get rid of. And
Yep.
some days we would have a million patients, and some days we might not have any. But I think there are other ways we can contribute to the department even when we don't have patients
Yeah, I
outside of
think,
patient care.
yeah. And even patient care that's not skilled PT patient care.
Right. Right. And I think that still benefits patients, right? With delirium prevention, safe patient handling, all of those things. Making sure people have eaten.
Yeah.
Yeah. I want to ask you a couple of questions about your experience in the emergency department. So, one of my favorite things about being in the emergency department is keeping patients out of the hospital. So, my friend Sarah says that the ED is like the front porch of your house.
Hmm.
And you're okay having people come sit on your front porch and chat with you, but you're not inviting everybody into the house. You know what I mean? So
Yeah.
I feel like EDPTs can help be the gatekeepers to your entire hospital system and help manage resources. So what's your experience been with that?
Well, this week we're feeling that I think pretty heavily. Our community is getting hit hard with norovirus, flu,
Mm.
RSV. So we have a lot of patients, unfortunately, boarding in the ED, and a lot of patients that are coming into the ED with things that might normally get them admitted, but there's just absolutely no beds for them. So we're seeing a
Yeah.
lot of consults for those patients and the gatekeeping for the hospital and helping with throughput. So I think that analogy with the ED being the front porch is very accurate.
Yeah, especially if the house is already full, right?
Yep.
So if we can reduce bedlock in the ED
Hmm.
when we already have patients holding, that helps us keep people moving. It helps us get discharge plans in motion, because otherwise they might wait 2, 3 days to get up to the floor for an eval.
Yeah, unfortunately.
Yeah, I hate that. Especially with our older adults, when we talk about geriatric certified emergency departments,
Hmm.
when we're holding patients for multiple days in rooms with no windows,
Hmm.
on gurneys,
Hmm.
without mobility equipment, without like that nursing ratio where they can take you to the bathroom, where they can do purposeful rounding, when they can get you up to the commode, when they can make sure all your needs are met. I think we're really kind of setting up people for at a disadvantage. So I think PTs can help with that. But how do you guys explain to, say, your physician partners, I'm going to help avoid an admission and here's how? What's your elevator pitch?
I think it would be, that's a tough one. I've never actually thought about my elevator
Yeah.
pitch. Um, I think I'd talk to them about like, hey, this patient came in, they had a fall, living at home alone. You might typically admit them with ambulatory dysfunction, and then they stay in the hospital 2, 3, 4 nights until everybody gets in their room, sees them, documents them. But you get us in here for therapy day zero, we make the recommendation and can communicate immediately with case management and oftentimes get them out the door same day or lately in most cases next day. But it still addresses that backlog where you have to bring the patient in and let them sit for 2, 3 days and send them to the floor and then continue to slow down throughput with patients that come in after them.
Yeah. And then you end up with less bed luck.
Yeah.
Especially if you're trying to avoid those admissions that are observation admissions, right? Where
Yeah.
there's not any kind of the hospital's not going to receive a lot of payment for that patient being in the hospital. There's not a lot of benefit to the patient either, right?
Yeah.
So I think expediting getting the patient on to the next best step, whether that's rehab, whether that's home, whether that's hospital admission, I think what you're doing is expediting that process for them.
Yeah, and not only expediting the process for them, but also you kind of indicated this a little bit earlier, freeing up the physicians to go spend more time with those emergency patients that truly need the emergency care.
Right provider, right time.
Yep.
Yeah.
Yep.
So it sounds to me like one of the things that you're passionate about based on your experience in outpatient is musculoskeletal care. So I run into people who will say, I don't think we should be doing that in the emergency department. That's not an emergency. What do you tell those people?
I don't think it has to be an emergency for us to get involved. I mean, to the patient, it is an emergency.
It is.
Something
Yes.
about it triggered them to go to the emergency room. Um, Plus, too, if we can get involved sooner, we save that patient hopefully a lot of time, a lot of money, a lot of pain and
Here.
frustration, and
Yeah.
get them feeling better quicker. And then they don't have to come back again week after week.
Yeah. And I think this onus that we put on people to know whether something is an emergency or not is coming from the biggest place of privilege.
Yeah, we are very
Just
fortunate.
because, yeah, just because it seems obvious to us, well, I would never go to the ED for that. Like, I think that's one of my biggest pet peeves because for some people, they have nowhere else to go.
Yeah, they don't know. They might
Other
have,
people don't know where to go.
yeah. I mean, maybe somebody comes in because they have back pain, but to us, back pain is just, it happens to most people, but maybe they had a family member who had back pain that turned out to be cancer or something.
Well, also, just because something's not emergent doesn't mean it's not incapacitating.
Yeah.
So, you and I both have kids. Like, if I suddenly couldn't take care of my kids tomorrow because of low back pain, that would be a big problem. If
Mm-hmm.
I couldn't go to my work as a physical therapist because of a musculoskeletal issue, that would be a big issue. And I went through that, right? Like where I had to sit down between each patient and couldn't like had to take my shoes off between each patient because I had such a bad foot injury. Like it impacts people's lives to the point where it is emergent in that way. So
Yeah.
can you share like one of your biggest musculoskeletal wins in the ED?
I don't have any that come off the top of my head because unfortunately we don't get as many consults for that.
Yet?
Yet, yeah, I know. I would love to change that. I think we've had several patients that come in with that debilitating 10 plus out of 10 back pain and can't walk. In fact, one of them was a nurse in our hospital. He ended up in the ER because he had debilitating back pain and missed work, and I was able to get in there, and he still had pretty severe pain, but just educating him, doing a little bit hands-on stuff, getting him set with outpatient PT, telling him about a TENS unit. Like he was able to go home same day, and I think he still missed a couple of weeks of work, but within a month he was feeling better. And if we had just brushed him aside, he could have, I don't know, 3 months later, maybe still been off work or working, making his injury worse.
Well, and I hear people all the time say choose PT first.
Yeah,
Which I love that. Like, I'm 100% in. But where do I go for that?
right. Yeah.
If I hurt myself right now, where do I go to get a PT right now? If you wanted to see a physical therapist in your area today, could you? You already said you guys have a wait list. If you hurt your back today and wanted to see a physical therapist, could you do that?
No, it'd be a couple of days, and only a couple of days probably because I have contacts and they would wiggle things around for me.
Yeah. But still, that's a couple of days that maybe
Yeah.
you feel like you're stuck in bed, that you miss work, that you can't take care of your kids, that you
Yeah.
can't get up and down the stairs in your house, you can't get off the floor. Like, that's a problem. So when we say choose PT first, again, I feel like that's a luxury for a lot of patients.
It is. Yeah.
So, thinking about that, can we provide that emergent access to physical therapy, that urgent access to physical therapy, which is part of why I feel so strongly about there should be a physical therapist in every emergency department and urgent care in the United
I was just
States?
gonna say urgent care. My dream world is to have
100%.
physical therapy and urgent care offices.
And in our area, we also have mobile urgent care that will come to your house.
Oh,
So if I'm super sick and I need urgent care, I will call those folks and they will even do chest x-rays, IVs, like all kinds
wow.
of things in your living room. And it's doesn't cost any more than regular urgent care. And so I think about that too, like that concierge urgent home care physical therapy or going to wherever the person is when they have that emergent issue. Can you
Mhm.
come to that person and help triage that too to keep patients out of the emergency department?
Right. Yeah.
That would be cool, right?
Yeah. I mean, it would be cool for us as the physical therapist, but I think any patient that can avoid an ER visit or an extra doctor's visit would love it.
I know. I always joke with new grads that if they want to pay off their student loans, they should set up a tent in the parking lot that says have low back pain, start here first. And they could still charge a ton of money, but it would be way less than a $2,000 emergency room visit, right? You could be
Yeah.
like, $250, stop here first, and then, pay off your student loans like that. It'd be no problem. Question for you though about the outpatient to ED transition. So in the past, when I have provided training or mentoring for outpatient therapists moving into this environment, one of the issues that I've had people say to me is I wasn't prepared for the acuity. Like I thought I had seen patients with acute pain before, but this is so much different than that. So I feel like my normal approach doesn't work. How did you overcome that?
I don't know if I have,
That's a
honestly.
great answer.
Because every patient is so different, and even if you have five patients that all have back pain that started at the same time, they're all going to respond differently. And it's still, honestly, it still scares, I don't know if scares is the right word. It makes me a little anxious because I don't
Yeah.
know how I'm going to help them.
Yeah, it's challenging, I think.
It is, yeah, but I don't know. You just kind of have to do the best you can, and in a way, you're always kind of faking it until you make it. No.
Yeah, I've decided that I'm letting go of that term. My dad used to say that all the time. He'd say fake it till you make it. And now I'm going with show up till you glow up. That's my
Oh,
new phrase. Show up till you glow up
let's steal that.
cuz you're not faking it, right? Like you are bringing
No.
every bit of experience you have and
Yeah.
you're just trying things. You're doing what you can to make that person feel better. You're showing up whether you're sure about it or
Yeah.
not. So I love that.
Yeah. And I think if nothing else, if you're not making a difference on their pain level, you're still somebody that's there giving them an education, encouragement, making them feel heard because they might not be spending as much time with other providers who are listening to their complaints. And
Yes.
so if nothing else, I think they're gonna feel like, okay, there's one person on my side who's gonna help me.
Exactly. And that's therapeutic alliance.
Mm-hmm. Yeah.
I love that.
Yeah.
So, when you're working in this setting and you're worried about a patient, how do you approach the rest of the team with that? Like, if you feel like you have a concern, how do you make sure you're heard and not overlooked?
I think every time I've had an experience like that where I feel like there's something else going on, I've always had good experiences going to the providers and saying like, "Hey, this is what I'm worried about, XYZ." I don't know, you just have to be confident. Just
I agree.
explain your case.
So, how would you tell a new EDPT to build their confidence around their differential diagnosis, as well as like owning their expertise and challenging the medical team if needed?
I don't know because that is something I struggled with, and it took me a while myself to get there. I really don't know what advice I would give someone new. I
Yeah.
just try to encourage and reassure them that they know more than they think, and that even if they're wrong, they're still using their education and their knowledge, and
Yeah.
they'll learn from it.
And I think that you make a really good point with that, right? Like it's okay to be wrong.
Mm-hmm.
And I'd rather you be wrong and have said something
Yeah.
than have you
Yeah.
kept quiet and missed something, right?
Yeah.
So I think too, the other thing we forget about the emergency medical team is that they're wrong all the time,
Yeah.
both in positive and negative ways, right? Like they'll image just about anything just in case. But I feel like we are really hesitant to be like, I think this patient needs a CT scan. And we're
I
nervous that we're going to be wrong, right? But what, I mean, really, if you recommended something based on good exam and then it was a negative result, that's good information. You're not
right.
wrong. You've added to the workup and now we know for sure there's nothing wrong. But I think emergency physicians are taught to just like kind of cast the net. And so I think it's okay to be wrong. I'm just
Yeah.
gonna throw that out there. Like I'm giving whoever is listening to this podcast is 100% okay to be wrong, and I'd rather you be wrong than I'd rather have you miss something.
Yeah. And I think if you're wrong, the emergency provider that you tell to do X, Y, or Z is not going to remember and go, oh, there's Rebecca. She's that one that told me that this patient had a posterior stroke and they didn't. They're not going to remember.
Right. And more often than not, I feel like we're right, right?
Hmm.
Because we think about it very carefully before we are going to escalate that. Because I certainly don't want to be like with every dizzy patient that comes in, I think this patient needs an MRI. Like
Right.
I need to be a good steward of people's time and resources and things like that. So I think you get that track record, and sometimes you're right, and sometimes you're not. And what you get at the end of that is more experience.
Yeah. I think, and I'm sure some of that hesitation from anyone to approach a physician and say, hey, this is what I'm thinking. Maybe consider doing this test. You had alluded to it earlier where we think that the physicians should know everything. And so we almost put them up here on a pedestal because they have the MD or DO after their name. But I think that they would look at us and go, okay, these physical therapists know a lot about X, Y, and Z, and they would respect our opinion.
I
And
agree.
yes, they have to order physical therapy consult in many cases, but that doesn't necessarily mean that they're the end all be all.
Yeah. And bottom line is we're a team, and that hierarchy really should be very lateral because we're all
Yeah.
trying to do what's right for the patient. And
Yeah.
also, I think just educating them too about what your scope is. Like
Hmm.
in Colorado, we can order imaging. I don't do that in the hospital because that's a facility-based policy, but
Yeah.
I'm licensed to order any kind of imaging I want, including EMG. So to me, what I'm licensed to do is my bare minimum standard. I better be able to do all of that competently and accurately because I'm licensed to do that. So for them to know, hey, I'm licensed in this state to do this is helpful because then they know that I have a level of expertise that I can
Right.
contribute to that conversation. Oh,
Right.
did you know we get courses on pharmacology? Am I going to tell you what to prescribe for this patient? No. But I understand the mechanism of these medications that you're discussing and how they might impact this patient's movement presentation. So being able to have that conversation at the level that they understand and we understand, I think really just helps expedite care.
Yeah, I think that's a really good point.
So, do you love what you do?
I do. I don't get the Sunday scaries. I feel very fortunate. I see a lot of my coworkers experiencing burnout and just disengaged and a lot of turnover. And I feel very fortunate. I've said to my husband before, I almost feel like I'm doing something wrong because I truly enjoy what I do. I
I
mean,
think
don't
you're
get me
doing it
wrong,
right.
there are always hard days, but I don't know. I do. I love it enough that those hard days are they don't make a huge impact.
Yeah. So if somebody out there is thinking about like, I want to practice in the ED, but I don't think I can, what would you tell them?
I tell them that they could do anything, and if they don't think that they can because they don't have the education, there's lots of resources available.
Yeah, perfect. So what's your final shot, your top of scope tip for any physical therapist?
Oh, my top of scope tip.
Ah, well,
Huh. I think it would be don't be afraid to get in there, do what you know, do the Epley or the Dix Hall Pike, do the repeated motion exam on that patient with back pain. If something feels like it's off, chances are it's probably off. It's not going to hurt to tell the provider. But
trust your gut.
yeah, trust your gut. You know
Gosh, I
more
love
than
it.
you think.
Thank you so much for being on the show today. I really appreciate your time. You have been in the ED now and you're officially discharged.
Thank you.
Thank you for listening. In the ED Now is a podcast hosted and produced by Rebecca Griffith, the ED DPT, as part of Rebecca Griffith Physical Therapy, LLC. Our podcast makes you an excellent emergency department physical therapist. This podcast is intended for educational use only and is not intended as clinical or medical advice. While we make every effort for accuracy, factual errors may be present. Since you've been in the ED, I'm prepared to give you your discharge instructions. Please subscribe, share, and find more at theeddpt.com. You're officially discharged.